Maybe I'll just start with, I had a question for Dr. Shuckett. So if you take glucosamine sulfate, it's a protein, and you eat it, and it goes into the stomach and gets broken down, and how does it get into the joint? Or is that how it works?
Well,
is that simple, too simple?
It isn't a simple question. I think that's a real significant question when you're talking about taking a therapeutic agent for a specific organ. What is the delivery of the medication? Or in this case, glucosamine sulfate, how well is it delivered into the joint? And I think that that's a really good question because a lot of things you take are digested and go through the liver and don't necessarily get targeted to the joint. And these are very large molecules. They don't diffuse very well into the joint because they're millions of molecular weight molecules. So it's not really clear what the delivery is to the joint. Yes.
So did you hear that, what she said? No, okay. So I said, from the Arthritis Society, she said that the GATE study, the New England Journal of Medicine study, did not show much benefit for mild osteoarthritis. It was more moderate to severe. So if you're playing 9 holes of golf and you want to play 18 holes of golf, it's probably not for you, probably. Let's start with this one. What can be done for arthritis of the hip, of the spine, the lumbar facet joints, and the neck? So what can be done for that? Aside from what you said, anything?
Yeah, well, the things that can be done for that, can be either a general systemic treatment if we're talking about medication. So again, pushing the Tylenol, using an anti-inflammatory drug with all the considerations. Are we going to use Celebrex and protect the stomach? Or do we more favor using a traditional anti-inflammatory, perhaps with a medication to protect the stomach? Or there is local injection treatment that can be quite useful. So you can actually, it's done at the hospitals. Unfortunately, I must say it's a long wait to get in for patients, but you can get a facet block where they inject freezing and sometimes a bit of cortisone into the facet joint. If we think that your pain is coming specifically from a certain facet joint. And between MRI and bone scan and clinically, sometimes we can finesse just what facet joint is the problem. It's not always that straightforward. But and there is surgery, but surgery is generally not done of the spine unless there's spinal cord or nerve compromise, which isn't generally an issue with facet osteoarthritis. But again, you'd use the same systemic drugs. You might be referred for a facet block, as it's called, to the radiology department of a hospital, and they do it under X-ray view.
And, there is another procedure by one of our colleagues. I won't say his name. Okay, it's Dr. Badii, B-A-D-I-I. And he arranges to exactly what Dr. Shuckett said. So they'll freeze up a facet joint. They'll try to find the one that's the culprit. And if it's just one, they could put in a little electrode and knock out the tiny little nerve that goes to that facet joint permanently. So if it's one spot that's causing the pain, they could knock out the nerve.
Yeah, that's called a radioablative neurotomy. It's generally done by very specialized doctors. And as Dr. Shojania said, it can work more permanently. Sometimes it has to be redone after a year or two, but it is a more permanent way because facet blocks are quite temporary. So sometimes the doctor will do a facet block diagnostically, say, yeah, it's coming from that spot, and then say, now we can go back in and we can do something more permanent.
This goes to the next question, too, and I think to answer the first on this one, I have osteoarthritis of my neck, C5 and C6, tried all types of pain relief from Tylenol to Aleve to Tramiset. Now I'm on Celebrex, but still in a great deal of pain. Any suggestions? There's a second part to that.
And that's of the neck?
Neck.
Neck.
So
Yeah.
anything, what about exercise? What exercises should she be doing, or he?
Well, I mean, I would do with anybody with chronic pain. You should be doing range of motion exercises. You also should be doing a lot of walking or something aerobic to help block the pain. So we know that being in good aerobic condition can help decrease the pain. Are you suggesting, Kam, any specific neck exercises? Or?
Yeah, I was, I think what I've noticed in myself now that I'm middle-aged and my colleagues and my patients is that our posture is very bad for neck osteoarthritis, and it's working at a computer, walking like this, right? If you tuck your chin in, you stretch out and open up those facet joints. And that's key, but it's hard to do that all the time if your belly is not strong too, and your back. So if you start to walk around like this, you need to get all of these areas very strong to improve that posture. I think that's...
So core muscle
core strengthening and cardio. And don't come talking to us about more pills until you're doing all of those exercises every day.
And next, and I really empathize with the person who asked this question, because neck pain it's a very frustrating pain, and they've been more innovative as far as doing lower back injections than neck injections, but by all means, the kind of injections that Dr. Shojania and I talked about, for instance, if it's coming from the facet, doing a facet block, and radioablative neurotomies are certainly done in the neck. So if it is coming again from a more specific facet and it can be shown clinically and by imaging that joint is the culprit, then there are procedures, as we just mentioned, that can be done. But it's difficult, and it's a long wait to get each thing done because these practitioners are so busy and so in demand because these are common problems.
What's your opinion on marijuana for pain control? That's not my question. That's a question, right?
Well, it's very much a matter of philosophy. I don't want people in the audience to think, let's go see her. She's going to write me for medical marijuana. But, I think that a lot of drugs that we prescribe have more side effects than marijuana. That's my opinion. And, I think it depends. There's sort of a threshold but if people are in severe pain, I mean, we do have a drug called Sesamet that is a cannabis-containing medication or like a marijuana-containing pill. So sometimes that is used. I have a couple of patients who I have put on medical marijuana, and I've had patients abuse that privilege. So I don't really enjoy filling out the paperwork and putting people on it because I do find some people that I really do feel are abusing it. But, when you're having severe pain, we're so compassionate with end-of-life pain, cancer, palliative care. We're so compassionate with that, but people with arthritis and certain conditions that we treat suffer from a great deal of pain. And there's a lesser openness about treatments like that in people who have arthritis. So I don't have a closed mind to that idea at all, particularly if the patient and the doctor are sort of in a contract and agree. And I know Health Canada will only okay a certain amount. I just feel there are some people who I do get the feeling might be abusing the privilege for other people. Similarly, using Tylenol number 3, I mean, it's okay to take a few Tylenol number 3 a day, but, and now there's Tramacet or Ultram, Tramadol, which are those are opiate narcotics, but they're not as big league as being on morphine and Percocet and oxycodone. But I think that being on those types of drugs, they're addictive. There's no two ways about it. And because you're probably going to lead a long life with your arthritis, it's a lot harder for the physician to take the pen and write you a prescription for what is truly going to be an addictive drug. And often the dose of these drugs escalates over time. You just see a pattern of creep up, I call it, of the dose. So it's different from being in a terminal case in which event, morphine is used very, very, very openly. So It's a challenge for people with arthritis because the morbidity is great, and the pain, there's no doubt that it's bad pain, and yet we're not very permissive about those things in chronic situations. And I really don't know what the answer is. I worry when I see people going on narcotic analgesics beyond Tramadol or Tylenol number 3, but I wish I had the answer. I'm afraid I don't.
Are there thumb replacements for very weak and disfigured thumbs? Someone, you showed a picture of osteoarthritis. You talked about the fingers. What about the thumb? I see in the audience and people with thumb arthritis. What can they do when they can't pick up stuff?
So the thumb, at the base of the thumb, it's called the CMC joint, or the first carpal metacarpal joint. And some of you may have arthritis in that area, and it becomes quite squared because you develop some osteophyte, some of that new reparative bone that I mentioned earlier. And yes, they can, sometimes we'll do a cortisone injection of that joint, or we can get a splint made up that can really help immobilize that joint. And you're using your thumb in everything. So having arthritis there, I mean, some people it's mild, it doesn't bother them, but it can really be a problem. And in fact, I said generalized OA of the hands. Doctors will tell you, well, it's not rheumatoid arthritis, it's the milder form of arthritis. But when you have arthritis in that joint, it can really, really hurt. And yes, they can actually do a joint replacement in that site. Or I noticed some of the orthopods, what they're doing now is they're taking a piece of ligament and or tendon and interposing it between the bones to sort of create a surfacing and create a new joint space. So yes, if it really, really is bothering you and it's not working out for you to have a splint, there are procedures that can be done. And actually at St. Paul's we have a very good group of orthopedic hand surgeons, and I certainly refer to them, and or some of the plastic surgeons do these procedures, and that is a reasonable way to treat it. Yes, there's a question in the back.
I just want to go off on what you said about the needles forming on the bones. I just want to ask, why does that happen? How does that happen with the bone?
The new bone formation? Yeah, so those osteophytes, we don't know. It's a bit of a mystery why they form. It's as though they're trying to create they're like little hooks at the end of the bone, and it's almost like they're trying to anchor the bone and recreate the cartilage and create a joint space. We sometimes call them traction osteophytes. So it's interesting because in rheumatoid arthritis, you don't get osteophytes. Rheumatoid arthritis is a disease of subtraction. You get osteoporosis in the area of the joint. You get joint space loss. You don't get any regeneration. But in osteoarthritis, the cells of the cartilage, the chondrocytes, are really working hard to make reparative tissue, and so they make these osteophytes. And it's not really clear that the osteophytes really do accomplish very much, but it is a reparative phenomenon. And it seems to start because you get little ingrowth of blood vessels at the margin of the joint. So it starts off as a sort of ingrowth of blood vessels, and then you get this cartilage that isn't even the right kind of cartilage for what the joint wants, but it's a mysterious reparative attempt in osteoarthritis. And sometimes it may work in some people who don't go on to have, end-stage bone-on-bone osteoarthritis. Maybe the osteophytes do accomplish something in some of these patients. Well, when you first, for instance, in the fingers, before you get an osteophyte and get what I call those Heberden's and Bouchard's nodes, you often get a red-hot, painful kind of cystic swelling, like a little pocket, like a little water blister in the area. And that can be very painful at the beginning. But the osteophytes usually don't hurt over time. It's the bone rubbing on the bone in the joint itself that gives most of the pain.
Does weather affect osteoarthritis?
I think weather does affect arthritis. I mean, because patients are always right, and patients tell us that. I mean, there's no doubt people tell us that they feel worse at this time of year. And it may have to do with barometric pressure. It's quite a mystery, actually. I believe that it does make a difference.
I tell people there's just as much arthritis in Prince George as there is in Arizona. And
that's true. I know when patients say to me, should I move to the interior? Should I move to a milder climate? I say, don't sell your house. Don't do anything. Do a pilot run and go there for a winter and see before you sort of buy a new place, because you just can't predict things like that. Again, those things are so relevant clinically to patients, but they're so hard to study properly and understand.
Cortisone or viscosupplementation, why one over the other in reference to an 86-year-old with severe osteoarthritis of the knee? Why would you suggest one or not the other?
Well, the cortisone injection may kick in quicker, and that may be an advantage for somebody at that age. I wouldn't mind so much if somebody's 30 years old and you're doing cortisone injections every 6 months into a knee. I don't think you'd want to do that, but I think later in life, again, it's somewhat of a palliative treatment to the joint, but cortisone injection will kick in quicker, but it may not last as long. And I have patients in that age group in whom I do cortisone injections and some in whom I do viscosupplementation, and it's often a decision based on a conversation between the doctor and the patient, because every patient is an individual. So cost may be a factor, although if you have extended benefits, many of them cover viscosupplementation a certain amount a year. So cost sometimes is too prohibitive to some people who don't have extended benefits. So that can be a factor. Yes.
Doing one then the other?
Yes, you could
comment
stagger
of trying
them.
one versus or the other alternately.
You could stagger them, and I've done that with patients. We don't think it's optimal to put the cortisone in at the same time as the viscosupplement, because then you're changing the viscosity of the viscosupplement. But yes, absolutely, you might do them both, but do them in alternating fashion. Kam, you don't do too many cortisone injections for OA of the knee, do you? Because I think we've talked about this.
I've been pushing exercise a lot, and I thought I have a little contract. If you can get your exercise, strengthen the knee, which doesn't have to be walking. It can be non-weight bearing if walking hurts. Weight loss, even 10 pounds of weight loss will improve knee OA symptoms better than most medicines. And if that doesn't work, and I record the weight, so you're not going to want to come see me because I record your weight and I berate you. No, I don't do that. But then in that case, I'll do it. I'll try the injections. But I really need to get people doing what they can do first, and then I can add it. Which is longer? Is that what you're saying?
Well, cortisone injection, you put in the freezing. The freezing comes out after a couple of hours. But cortisone, you start to see an effect within 1 week or within 1 to 2 weeks. But it probably reaches a peak, and then some people, they're still doing okay at 4 to 6 months. And then they come back for another one. The viscosupplement, it doesn't peak till, I think, around 8 to 12 weeks. It's quite a slow peak, but it probably lasts longer. It's sort of maybe a better investment for maybe changing the process that's going on. But like I say, sometimes it works and sometimes it doesn't work.
The other thing I know that we both do is that if the knee, osteoarthritis isn't just wear and tear, as Dr. Shuckett said. If the knee is a little warm or it's a little fluid in it, I'll do a steroid and cortisone injection because they respond very nicely. If the knee is really cold and not inflamed, I may lean towards the Synvisc or the hyaluronan injection. Is that about?
That's a great answer, yeah. Yeah, I wish I said that.
Is chondromalacia patella due to or caused by osteoarthritis?
So chondromalacia patella is sort of a fissuring or a wearing out of the kneecap, but it's, remember I showed you that cleft in the cartilage? There are fibrillations in the cartilage, so the cartilage is a little irregular and a little bit in tiny little areas worn out. But chondromalacia patella is really common, particularly in athletic young girls. It's common, and it may or may not progress. if you do have chondromalacia patella, there's a greater chance that it might progress to osteoarthritis of the patella or the patellofemoral joint, which is the joint between the kneecap and the thigh bone. But we often think of chondromalacia patella as an example of non-progressive fibrillation. Remember I told you, if we could figure out what causes fibrillation to progress, and if we could block it, we'd be much further ahead in treating OA. So chondromalacia patella is a sort of, it's a diagnosis that is mainly made probably on arthroscopy rather than a clear diagnosis on X-ray, or you may see it on an MRI scan. And it may or may not progress to patellofemoral osteoarthritis.
Go ahead.
Just a question. Is there not osteoarthritis of the shoulder because there's moving joints there? And I didn't hear
Yes.
any discussion on
Repeat
that.
the question.
Okay.
What about osteoarthritis of the shoulder? It's a joint. Why didn't we hear anything about osteoarthritis of the shoulder?
Yeah, there is the acromioclavicular joint between the collarbone and part of the shoulder. And that joint, even by the time you're 20 years old, people are starting to get fibrillations and fissuring of that joint. And it is a common area for osteoarthritis. A lot of people have it incidentally on a shoulder x-ray, but it may not be where their shoulder pain is actually coming from. In the true shoulder, like the ball and socket of the shoulder, there is one particular, osteoarthritis is not that common in the shoulder, but if you have calcium crystals of certain kinds, you may develop a type of wear and tear of the true shoulder joint that is sometimes associated with a tear of the rotator cuff. So we often think about crystals when we have major wear and tear of the true shoulder joint. Otherwise, it's mainly acromioclavicular joint wear and tear.
Would you use hyaluronic treatment with crystal arthritis?
I think it would be less likely to help when there's chondrocalcinosis. I mean, I'd be more inclined to consider a cortisone injection because there's an inflammatory process. The crystals are very pro-inflammatory, so we often call those inflammatory forms. And like Dr. Shojania said, often they have a little bit of fluid in the knee. And so you might prefer a cortisone injection.
Here's two that are very close, so I'll say them together. Is it common for a person with osteoarthritis to have constant, widespread aching in the body even while resting? What's happening? 1. 2. Is it common to have two types of arthritis at once?
Yeah, well, those are good questions. First of all, osteoarthritis, sometimes people are suffering from osteoarthritis of a generalized form that's in multiple joints, and they may feel a pain all over. And, there's a whole list of differential diagnoses for pain all over. It may be the osteoarthritis, because when you get osteoarthritis in your neck or your low back, the pain can refer out and fan out to adjacent muscle areas. Another thing you'd want to make sure and maybe check for fibromyalgia, because anybody with any form of arthritis is more predisposed to develop an achy soft tissue pain called fibromyalgia. It is possible, absolutely, to have more than one type of arthritis, even if we're just talking about the peripheral joints. So rheumatoid arthritis affects about 2%, 1 to 2% of the population, more women than men. And osteoarthritis with aging, I said, can affect up to 50% of the population. So when you put those two together, you are going to have some people who may actually be unfortunate enough to have both. And so, yes, more than one type of arthritis can coexist.
This one might be hard to answer, but I'll read it out. My left foot is what looks like a bunion, big toe, a bit uncomfortable but not painful. That foot always feels colder and stiffer than the other. Could it be osteoarthritis?
Yeah, it could be osteoarthritis because a bunion sometimes represents an osteophyte or new bone formation. And so an x-ray would tell you and your doctor whether that toe joint, called the first metatarsal joint, metatarsal phalangeal joint, an x-ray could show you whether the joint is narrowed and worn out and whether there's some osteophyte or new bone formation around an area of osteoarthritis. So it definitely could be osteoarthritis. Now, it could be chronic gout, and an x-ray would probably help show what that is, and maybe a blood test. Why the foot is cold, sometimes when you have a very sore joint, you get this sort of, we call it a vasomotor, so the blood circulation changes in that area. I mean, I would want to double check that your circulation is good and that you have good pulses in your foot if you have those changes in your foot.
Last question.
Stay on that subject.
Yeah.
Circulation and the coldness in the extremities. Would that have any correlation to the joint damage or anything?
So the question is, what about coldness and reduced circulation? Because the other cold foot might have reduced circulation, you said, right? So does the cold relate to any damage to the extremities? Is that basically okay?
Yeah, you don't generally get a cold hand or a cold leg unless there's something to do with maybe spasm in the blood vessels to that area. There is something rather uncommon, but we do see, called complex regional pain syndrome. So there are some conditions where you get, for instance, injury to a foot, and then you end up with a cold, bluish, purplish foot. And that can be a specific type of increased sympathetic blood outflow to an injured area. So there is such a thing as that, but it's not that typical with arthritis to have a cold joint, and certainly with rheumatoid arthritis and very inflammatory arthritis, you tend to get a red-hot joint. So a cold extremity, it may be a response of the blood vessels to pain, but it's not really part and parcel of arthritis.
Last one. If someone has an intra-articular fracture of the big toe as a teen, is there anything the person should do to watch for early signs of osteoarthritis? Are there any screening or testing, any early intervention that can be done?
Well, I think that if you're symptomatic or if you're concerned that you're going to develop osteoarthritis, which will be an increased risk when the fracture is through the joint, I think monitoring for pain and stiffness, those are the symptoms that you're going to get. You could see whether you develop like a bunion and a bony fullness over the area. And you can get a plain x-ray. I mean, you could get an MRI scan, but I don't recommend that. I think MRI scans can be useful sometimes for detecting osteoarthritis, but an x-ray is by far the main screening test for that. And so if it is symptomatic or if you're concerned about it, you could get a plain x-ray, and that will show whether the joint space is narrowed and whether you're losing the cartilage of the joint.
Actually, this one I forgot. I thought we did talk about it, but does regular exercise reduce the risk, something else we didn't talk about, of osteoarthritis?
Well, probably regular exercise does reduce the risk, because if you've got really good muscle tone, your muscles are going to be a good shock absorber and put less wear on the cartilage to absorb, your weight bearing and trauma to the joint. Also, we know it's really interesting. I told you that obesity is a risk to osteoarthritis of the knees and probably of the hips as well. But it's interesting that obesity is even a risk to generalized osteoarthritis of the fingers, which isn't a weight-bearing joint. And there's something called leptins, which are sort of from fat metabolism. They're proteins that are released when people are overweight, and they may promote osteoarthritis to some degree. So it's not just simplistically, you're putting 3 times your body weight through your legs, and that's why you're at risk for osteoarthritis of the knees or hips. Even OA of the hands can be a greater risk in obesity. So I think regular exercise helps prevent obesity. It helps muscle tone and compliance and support of the joints. And I think that it's an excellent preventative thing to do.
So the top 3, I just wanted to put her slide here. The top 3, she didn't put them by accident, the top 3. Physio, cane, and a brace. Maybe not the brace, as she said, it's a bit uncomfortable, but these have all been shown to be a benefit in osteoarthritis, not a pill. Weight loss and muscle strengthening have been shown to be of benefit. I think those are really the top, the most important things we should be we should be working on. We have patients that come into us all the time and they say, Dr. Shuckett, now I know you're going to tell me to take pills and I just don't want to take pills, so give me some advice. And she'll say, I want you to lose weight, I want you to exercise, and they start to glaze over and then they say, can't you just give me a pill? So we have to really try those important factors before the pills. These are the end of the written questions. Any other questions? Right here.
Question I have is, I have a friend who's been diagnosed with this for 8 years ago with a type of arthritis, which has been mentioned. It's called Sjogren.
Okay, so can I, any further to that?
No,
I'll mention. So a type of arthritis called Sjogren's. What's that, Dr. Shuckett?
Well, Sjogren syndrome is a drying or inflammation in some of the glands that produce secretions. So typically with Sjogren syndrome, people have very dry, gritty eyes, and they find they need natural tear eye drops or lubricant in their eye to help the grittiness. It feels like sand in their eyes. And they typically have a very dry mouth. Sometimes it may be hard to chew and swallow a cracker or something because they're just not producing the saliva. And it can occur on its own. It's not particularly in the true sense. You know, a lot of people, and normally with aging, particularly women, do get dryness in those areas. But it can be a disease of itself called primary Sjogren's. Or it can be associated with other types of arthritis like rheumatoid arthritis and lupus. But we know that with normal aging, there is decreased secretion of these glands. So just if you're sitting in the audience and you have dry eyes, dry mouth, don't worry, you probably don't have Sjogren syndrome per se. You have what we call sicca or dry symptoms, but it doesn't mean that you have the full-born syndrome.
We'll take that right there. Blue, yeah, scarf.
A couple of questions. One is, when you talk about exercise, is running bad for the joints?
Is running bad for the joints?
Okay, there have been a number of studies on that, and there is no good evidence that running promotes osteoarthritis of the hips and the knees. Somebody by the last name of Nancy Lane did a lot of studies on that. And I think it's because, you know, people, and even marathon runners, they're in such elite condition that their muscles are probably so toned and they've got so much compliance in the supporting structures around their knees and hips that there doesn't seem to be a risk. Now, with that being said, this is somewhat theoretical, but if you had some of the things I mentioned, like, and we often don't know till after the fact anyways, but if you had a shallow acetabulum, or if you had the femoral acetabular impingement syndrome, that is probably a hip that you shouldn't ideally do long-distance running on. But, you know, like I say, we don't do screening MRIs of the whole body in people in their 20s, 30s to say, oh, yeah, you have this anatomy. Maybe don't do running if you don't mind and pick a different kind of exercise. But so if you have an anatomic variation or a really long leg on one side, it's probably not quite what the doctor ordered for your particular architecture of your joints.
Question right here. Pink.
Considering that more women get away than men, have they done studies with any inclinations towards the hormonal implications?
So the question is, given that women have more osteoarthritis than men, what studies have been looking at hormones or other differences in the genders?
Yeah, there are very many studies that have been done looking at hormones, and unfortunately, they're so inconclusive. You know, and there's estrogen, there's estriol and estradiol, and all the metabolites of estrogen, and various papers which describe various differences or risk factors, but there's never been a consensus on the effect of hormones, and yet it's obviously extremely important because osteoarthritis, particularly of the hands, tends to occur right around the menopause time or after menopause and rarely before. So there's no doubt hormones are important. And yet if you just put somebody on some Premarin or some estrogen preparation, unfortunately there's no good evidence or conclusive evidence to say that it helps. But you're quite right, in most diseases in rheumatology and in the field that Dr. Shojania and I practice in, women are greater than men 3-to-1. Lupus is 10-to-1. We know hormones are extremely important in lupus, but in osteoarthritis that's so common, we don't seem to know what the answer is. There are many studies, and if you Google it, you'll find a lot of interesting information on it, but it's just so inconclusive and sometimes contradictory that it unfortunately doesn't help us in our treatment of our patients.
Men have gout, though, and it's really painful, so you know.
Yeah.
Follow-up.
I have a different question. In osteoarthritis, do the nightshade plants affect it? Are they more implicated in rheumatoid arthritis?
Nightshade plants in the treatment or avoidance? Avoidance.
The avoidance.
Yes, okay.
Suggest that they don't cause it, but they can once you've got arthritis. But is it
Well, you know, diet and arthritis is really a challenging area. And again, it's very idiosyncratic, like it's very individualized for a given person. Unfortunately, again, these things aren't studied in the rigorous way that drugs are studied. So most traditional doctors are going to kind of give you a blank look when you talk about what diet you want to follow. And, you know, historically, we in medicine have really been very deficient in our understanding of nutrition, and clearly nutrition is very important. But I would say that comment about the nightshades, which are things like potatoes and tomatoes and those sorts of beets and that sort of thing, that has been discussed for rheumatoid arthritis, not so much for osteoarthritis. And yet, to what degree it has merit, I don't really know. We know diet can be important in gout. We know diet can be important in, it's probably better to have fish and vegetable oils rather than have a lot of animal red meat and animal oils. But it's really, really not clear as far as diet. And I hate to see my patients restrict themselves too much. Like some of them will go on an elimination diet and then maybe with the help of an allergist gradually introduce other foods in. We know that if you fast, arthritis gets better while you're fasting, but fasting isn't a good long-term treatment for arthritis. But the nightshade concept has been touted for rheumatoid. I don't really know that I subscribe to it, but again, I admit I'm a traditional doctor and there's so much I don't understand. And I never argue with the patient if they want to go on a diet or try a naturopathic treatment that I don't think is of any harm. It's good to just communicate with your doctor what you're doing. But some people have, celiac disease or gluten intolerance. But again, I hate to see people go on really restrictive diets. And particularly with a condition like rheumatoid arthritis, we know that we need traditional drugs in rheumatoid arthritis. And if diet is a player, it's not a big player in rheumatoid.
Maybe back there and then back. Ice or heat?
What's better, ice or heat? It really varies for a given joint and a given patient. Typically, icing, when you sprain an ankle, we tell you to use rice, rest and ice and elevate the joint. So when a joint is acutely red hot and swollen, ice can get some of the edema or swelling down. Whereas if a joint is chronically symptomatic, putting heat on it may be more soothing to some of the muscle spasm and may improve the circulation in the joint area. So icing is not as useful in a chronic type of arthritis like osteoarthritis. And icing is more useful for a more acute inflammatory situation.
I would agree with that. I also think that, so for osteoarthritis, if it's, sometimes you can make it inflammatory by accident. If you're playing 18 holes of golf and your knee is now really sore, there may be some inflammation there. So when you're having your beer, you can ice up your knee at that point, right? That's what I would do.
Right, some preventative icing.
Yeah, preventative icing at the end, and then heat in the morning to get going. Often.
Is that what you do?
That's what I do, except that champagne usually. But, right. That was the same. Oh, good.
You mentioned celiac. My niece has celiac, or had at one time when she was younger. Would she be prone to advancing into one of the arthritis?
That's a good question. Celiac, can you be prone to developing arthritis?
Well, celiac is sort of a bit of an autoimmune type disorder, and the answer is yes, that there can be a link between celiac and arthritis. But if she has celiac disease, she's probably on a gluten-free diet, so she's probably going to be fine in her joints. I would predict that she wouldn't have any joint problems. But sometimes there is a link between inflammatory arthritis and celiac, but if you're on the appropriate diet, you really minimize that risk.
Speaking of the diets, a lot of my patients who see a naturopath or other types of physicians will say that they feel a lot better with some restrictions of their diet, and they often say the same things. I don't know anything about it, but they say sugars, dairy, wheat, and one more thing. All the good stuff, basically. And they say they feel better. And I don't see a big problem with avoiding those things because, they're not essential. And you still get all your vegetables and you can get all your proteins. So, I don't know. I have no idea whether it works, but that's what they say.
I think that, and I know in this lecture I haven't really said much about naturopathic treatment, homeopathic, but I think that doctors are in general respecting more that patients do want to do lifestyle type changes. As Dr. Shojania said, for the osteoarthritis and also for fibromyalgia, exercise and being as fit as you can is probably one of the most important things that you can do. But patients do want to merge naturopathic or homeopathic treatment sometimes with traditional treatment. And again, in most cases, sometimes people take something that isn't good for them that's naturopathic. Not all things naturopathic are necessarily good for you. But for the most part, there's probably little harm done. And if you are prepared to invest the time and the expense in trying those things, if you've got something like osteoarthritis, something chronic and slow progressing, there's probably not a lot of harm done. In rheumatoid arthritis, we so much know that we need to use traditional medications to treat it. But I think if you have chronic pain that's, not that deforming, if it's osteoarthritis or fibromyalgia, if you want to go the naturopathic route, I think there's not a lot of harm done. And hopefully your physician, just communicate with them what you're taking, and hopefully your physician will allow you to do that, because it is your body and you should decide what you take and what you don't take.
We have a standard story that we do at Answers Line when people call in. You remind them of that. Well, we try to encourage them that osteoarthritis is one of those ones that the less you do, the worse it can get.
So the less you do, the worse it can get. That's a standard for OA. I agree.
We need to move our bodies and just have to move and find a way to do it healthily.
Speaking of moving,
Some motion in the audience.
I think we're going to wrap up. Thank you very much for your attention.